Okay, good evening, everyone, and welcome to this evening's webinar on research from question to publication. So, to begin this evening, I'd like to start with an acknowledgement of country. So, I'd like to acknowledge that this meeting is being hosted from the traditional lands of the Palawa people. And we recognize the traditional owners of the land where you all work today and the First Nations people present in this meeting. We pay our respects to all elders, past, present, and emerging. As a way of giving a bit of background about eMedici and who we are, so we were founded in the 1990s by Professor Peter Devitt, and we are an educational provider as well as a community of practice. So we deliver a series of educational opportunities as well as products in terms of question banks, OSCE stations, and case studies, and a series of webinars, which is where you've joined us this evening. We provide dedicated support to medical students and doctors across the entire spectrum of training, so from medical school to fellowship and even beyond. We're an approved CBD provider, and as already said, we have a series of education webinars, and those can be found on our website. So, in terms of just before we jump into some introductions, this evening, if you wish to ask any questions, then please use the Q&A function within Zoom, and we'll endeavour to respond to your question. So, my name is Dr. Addison Davis. I am a rural journalist and the education and engagement lead at eMedici. We're joined tonight by Dr. Hannah Pham, who is the editor-in-chief, Dr. Marita Bollick, who is a junior doctor and associate editor, and our guest this evening, who will be taking us through all of the exciting aspects of research, is Dr. Karan Varshney, who's also an associate editor at eMedici. And Karan is a basic physician trainee in Victoria with extensive experience in the domains of public health and research. With more than 50 peer-reviewed publications and 20 conference presentations, Karan is dedicated towards using research to help make a difference in the world. His research interests are vast, with examples ranging from antimicrobial resistance to health programs in low middle income countries, to evaluation of clinical trial data, suicide risk in diverse populations as well. Karan finds great joy in teaching others about the research process and in helping people to navigate in this domain. He believes that any and every clinician can benefit from education regarding research. So, welcome, Karan. Thanks for joining us this evening, and very excited to hear what you've got to tell us all about the process of research.
Great. Thank you so much, Addison, for your introduction. And thank you all for taking the time to join us today. So getting right into things, put this on the screen there. This word for different people can evoke, different kind of emotions, different kind of feelings. For some, it's wonder, curiosity for knowledge, and a desire to advance knowledge. But the reality is, for some, it can evoke dread, frustration, and for some, it's just a nuisance. And the purpose of my presentation today is to shed some light on why this is important, as Addison said, introduction for any and every clinician. While it can be quite interesting, and there's a lot to be gained by understanding research, whether by producing it or by just simply understanding it. So in terms of the structure of the presentation today, I'm going to talk a bit about research and why it's important, why it's useful. I'll go into some of the nuances of different study designs, pardon me. And then I'll give a bit of a walkthrough about systematic reviews and how they're done and the kind of the process for that. So the why. We hear different things from different people. It's good. It's important. It's required. And in some cases, that's kind of the limits of what we're told, right? We're told all these things, and then it's go ahead and do it. Whether it's, for certain programs, such as for physician training, completing physician training and thereafter for a specialty, for general surgery, whether it's, a requirement as part of the program, but also for producing publications to get on the program. Emergency medicine being another example where you're required to publish a peer-reviewed paper or do a presentation. But again, you're kind of a lot of people are just told, this is something we have to do. Um, and then you're thrown into the deep end. You're not really given too much. You're meant to figure it out yourselves, which can be difficult. It can be difficult in terms of actually knowing how to do it and figuring out how to do it, but also having the motivation, the understanding of, why am I doing this? Why am I writing this long paper? Why am I digging through all these articles? Um, so with that, I'll give a bit of an explanation myself, very briefly. It provides a means to actually make a difference. It provides you with the capability to understand a problem better, whether it be a clinical problem, whether it be a public health problem, or it be somewhere in between. In some cases, it can also be finding a solution to a problem. So pardon me. So it can be finding a solution to a problem, through medications, through an intervention, through establishing guidelines. And ultimately, in some way or another, they provide the means to allow you to become a better clinician, to have better expertise, to better be able to serve your patients, because that's what research is able to do, produce better medicine. And coming back to why we do medicine, or so many of us chose to do medicine in the first place, that's have a bigger impact in people's lives. I think this all sounds great and it's wonderful. But I think it's also really illustrative to have some examples to really hammer this point home, all these different points. And I'll start by going a bit back in history, go back to the 1940s, to a pediatric pathologist by the name of Sidney Farber, who is today considered by some as the father of modern chemotherapy. Sidney Farber, when he worked back in his time, he would see many children get diagnosed with leukemia. And unfortunately, at that time period, it was basically a rapid death sentence where he'd see children, get this horrendous diagnosis. And within weeks, in some cases, even days, pass away from this brutal disease. And so one thing that Dr. Farber did was to really try to understand, besides just working as a clinician, try to understand what is contributing to this disease and what can be done about it. And one thing he found in his lab research is that folic acid, or folate, had an integral role in accelerating this disease and basically worsening the disease process. So that was one big discovery. Of course, it wasn't just him, it was him amongst others for Dr. Farber, but it was also the next stage of his work. So this is a molecule called aminopterin. And what Dr. Farber did at that time was he conducted a clinical trial basically assessing if a folic acid antagonist can work to address the disease. And this was, as far as recorded, the first case where complete remission of leukemia was established in children, and it was quite literally life-saving. We fast forward today, and we still see that, despite these discoveries of Dr. Farber, as well as many others who are ongoing today, this is a brutal disease, AML and ALL. On the screen there showing the 5-year survival rate is still nowhere near optimal. But if you look at that starting point right there in the 1950s, so this is right around the time of Farber's work, you can see the 5-year survival rate was essentially zero. And so I give this example to show how historically, there's examples where it can be a huge difference maker in people's lives. Going to the modern day, we know about pancreatic cancer. It's a disease with a very poor prognosis. However, very recently at a American's significant cancer conference, a clinical trial and the data was presented to show that there's basically a new medication that can double survival rates in patients. This work received standing ovation, and they're just showing that it's not just history. Research today can make a huge difference in people's lives through clinical trials. I also want to add, provide a different example because, the clinical trial thing is big, but not all of us will be doing research on such a large scale if we are going to be doing research. So I'll give the example of something that I've seen in the clinical space sometime in the past where, there's a Met call for a patient who's previously well, just had some new AF, relatively minor abdominal pain, likely, a typical admission that's probably discharged within a day or two. But when we went to the Met call, astonishingly, this patient had abruptly died. No signs of ST elevation, no signs of a heart attack, no signs of a pulmonary embolism. And the cause of death was simply not known. This is astonishing at that time, and it's a phenomenon that has been described and is actively people are actively seeking to understand this, sudden cardiac death with atrial fibrillation. And so the research is in the process of emerging, but it shows an example of, if there's more out there, maybe we can better understand this phenomenon and help prevent it, quite literally help save lives. give another example for those who are interested in research, but not necessarily from a clinical environment, more from a broader societal or public health perspective. And this is one some research that I produced. Back in medical school, we unfortunately heard of a case, not necessarily in my cohort, but in my medical school, of a student who passed away. And unfortunately, this is someone who lost their lives to suicide. It was devastating for many, and it really, as you would expect, it was heartbreaking. And so one thing that myself and other students really looked to was trying to understand this. How can we prevent this in the future? And so this is myself and a couple other students at the time who worked together to create a publication, and it's something it ultimately created an output that we've shared with the medical school, we've shared with other professionals, and it's something that's being seen now. And I bring up this example just to show that this is not something that producing research doesn't have to be something impactful. Research doesn't have to be something that's for someone who has a whole bunch of funding and is in a lab setting and has the means to do that day and night. It can also be for people who are interested and who are motivated to make a change. For those who do not actually want to do research, I understand there's a significant population or significant portion of clinicians who are in that domain as well. And I think it's still important to recognize that it's valuable in other ways. Developing expertise, being able to interpret, make sense of guidelines, recommendations, clinical warnings, and applying this to everyday practice, especially when something's new. So the example that I'll give for this is something like the new GLP-1 drugs, injectable drugs for weight management. These are very new. And yet we see that they're becoming more and more common, or at least the desire for them to become are becoming more common. Alongside that, we are hearing warnings of the potential risks of these drugs. Connected with that, we also hear about ways in which these medications can be helpful in ways that perhaps we're only starting to understand. That's balanced with risks that we're, again, only starting to understand. And so as a clinician, there's great utility in being able to interpret this research, to make sense of it, to digest it, and to use it to become a better doctor, to become a more informed clinician who can prescribe and make sense of things for their patient population. So with that part of the why, I'm going to move on now to the next part of this presentation, and that's study designs, to basically make sense of some of the research that we see out there, to help you with that. This is a hierarchy of evidence. You may have seen this before, basically describing the quality of evidence for clinical research as a whole. I do want to say from the get-go, this is nice and simple, and sometimes people think that it starts and stops here, and that's not the case. There's many other study designs, cross-sectional studies, so surveys, for example, laboratory studies, such as the one I talked about with Dr. Farber, preclinical studies, so that might be not necessarily clinical trials, but still work that's being done on cells or on people on an individual basis. And I'll just flash it here, don't get overwhelmed, but this is there's just a whole bunch of other different kind of methodologies. The point is not to aim to understand all of these, but the point is more so to see that we're given this hierarchy and it's nice and it's very useful, but there's a whole world out there that shows how rich and diverse this is. It can get even more complicated when we look at the actual types of publications that are available and the grade of evidence for those. I'm not going to go into all those. I just wanted to show you that it's there. So now we'll go back to this hierarchy. And what I'm going to do is I'm going to go through these different types of studies and kind of give a glimpse of what they are briefly, as well as how they can be useful. So case reports and case studies. These are basically small-scale studies following one or a couple patients over a brief period of time, or several months in some cases, to get an idea of something that happened with them, some kind of diagnosis, some kind of outcome, what the management was, what the investigations were. And they're typically, they're small in scale, so they're not meant to be, changing clinical practice, but they're more intended to be something, a means to understand phenomenon that's new or poorly understood. So for hypothesis generating. So an example that I can give of a case report as such is this one that talks about the emergence in a single case of vancomycin-resistant Staphylococcus aureus. Obviously, we know about MRSA and how significant that is. But this one poses, it's not necessarily widespread, but even single cases can be really instructive for understanding, new phenomenon. So I really want to emphasize the other point, though, going back, is the limited clinical utility of these. You might see in certain news reports, in some cases, even clinicians citing case reports, even researchers or case series to emphasize, evidence for something. And I want people to be aware that there's a certain level of caution that should be exercised with this because it's with such a small sample size, in some cases literally one, it can be provide very limited evidence in some cases. An example of this, that's been impactful, not necessarily the author's fault, has been, the assumption that soy is strongly associated with gynecomastia. This is a single case report that has in some cases been cited or described by researchers, but more frequently by those in the media who interpret research and say, this is evidence of a phenomenon that's widespread in practice, and it's a risk. And there's quite a bit of evidence demonstrating that's not the case. But the point is more so that the single case report has been quite influential in ways that perhaps were unintended, and it's valuable for researchers to understand the limits of these kind of studies. Next, I'm going to talk about our case control studies and cohort studies. So these are similar in some ways. They both are observational, as in you're not performing an intervention, you're not giving someone a treatment or a drug and evaluating the effect over time. Instead, you are still following this group, but it's more to see what's happened. And so how I kind of differentiate these, because they can be quite confusing for some, is basically cohort studies are looking to evaluate the result, the ultimate outcome, whereas case control studies are kind of going the other way around, where we have an outcome and we're trying to understand what the exposure was. So I'll give some examples of those. So for a cohort study, as a specific example, for those who have HIV, what were the factors associated with progressing to AIDS? We kind of already know what the exposure is, and we're evaluating what led to the outcome. Whereas something such as a case control study is, again, we're going the other way around. We know, so in this study, what they did was they looked at malignant mesothelioma and those who passed away from that, as well as those who passed away from other causes. And they looked to work backwards to see what exposures were associated with the development of this disease. In this case, asbestos and the extent of the burden of asbestos compared to those who did not develop mesothelioma had lower exposures or none in some cases. In a case like this, where it's well understood in the literature that asbestos is linked with mesothelioma, it's not necessarily as obvious how useful these studies can be. But in other cases, where we don't know necessarily all the factors associated, the example I gave before, pancreatic cancer, it can be quite useful in trying to understand how to prevent certain conditions or certain outcomes from emerging. Next are randomized control trials. So these are considered the gold standard for original studies when it comes to aiming to establish causality in medicine. These are, unlike the observational studies, unlike the case reports, case series, and the cohort and case control studies, these are actually interventional. As the name suggests, so this is a depiction here of kind of what goes on in a randomized controlled trial, where you're going to have a population and you're going to intend for them to be kind of as homogeneous as possible. So similar as possible in terms of ethnicity, age, place of origin, all these different kind of things. And then what's going to be done is randomly some participants are going to receive the intervention, so there'll be some kind of treatment, and in some cases, and the others are going to receive a control, so it's usually a placebo. The researchers, how it's intended to be is the researchers don't know who's getting the placebo, the researchers don't know who's getting the treatment, and the patients themselves don't know. So it's meant to be, and the clinicians, of course, as well. So it's meant to be as blind as possible. And then ultimately, you're trying to evaluate after the fact, after that's all done, the differences in outcomes. And so, yeah, as this kind of says, as it kind of insinuated there, you're basically controlling for theoretically as many confounding variables, as many variables that might get in the way, to try to determine what's causing this effect, and if it's that treatment that's doing that. It's worthwhile to denote randomized controlled trials are the gold standard, but it's not always the case that trials can be randomized or that a placebo control can be used, either due to issues of feasibility. So, for example, if the trial is about surgeries, it's not going to be clearly possible or desirable to have a placebo group that's going to have surgery conducted without anything going on versus those who are actually, say, getting an organ removed or something along those lines. In some cases, it's just simply not ethical to have a placebo control. And this might be in some cases where the standard, as the trial is conducted, the standard is so clearly superior to doing nothing that it's deemed as morally unethical to continue with a placebo group. So I'll give a historical example of this. This is around the 1970s with the usage of ARVs, antiretroviral drugs, to help aim to lower perinatal transmission of HIV in certain contexts. So the initial trial demonstrated a clear, significant decline of approximately 60 to 70% of perinatal transmission with the usage of ARVs, and the placebo group having, significantly lower. And after that, certain other trials were ongoing with placebos, despite the fact that there's such strong evidence. So the authors of this particular article, it's not the RCT themselves, they're making the claim that it's just simply wrong in this context to be doing that when we have such clear and strong evidence that it's worthwhile to give these treatment to people. So just, again, highlighting that there's nuances to these trials. In some cases, it can be the new intervention versus the standard of care. It can be a whole bunch of other things, and it's not so black and white. I thought I'd also just add on these cross-sectional studies and qualitative studies. These weren't on that hierarchy, but they're quite useful in the clinical context as well. They as well are observational, and they're typically at a single time point. That's not always the case with qualitative studies, but that commonly is. And they can offer unique findings from the patient perspective. So this is not necessarily, evaluating quantitatively the change in a disease, obviously because it's at a single time point, or, again, qualitative studies by definition are not quantitative, though they have some quantitative elements they can. It's more so to try to get a gauge of the perspective. And in some contexts, that can be as useful or can be a great augment to the findings in the clinical space. So for a cross-sectional study, for example, this can be a perspective from treating physicians and what they think and what they feel for something like end-of-life decision making. Qualitative studies, so in this case, it was an interview. It can be useful for understanding drug non-adherence. So we know that, metformin obviously is quite effective in type 2 diabetes. But a study like this might help a clinician to understand, okay, I know and they know that it's useful, but they're still not using the metformin. Here's how, the findings from, as an example, a finding from this kind of study can help a clinician better understand how they can support their patients in ways that are not necessarily strictly related to the biochemistry, to the pharmacology. So add-on qualitative studies can have unique approaches themselves. So interviews, semi-structured interviews, fully structured interviews, focus groups. They can even be just a full text response on a survey. And so you see a lot of times studies that takes a mixed methods approach where they have a cross-sectional survey as well as the qualitative component. Again, having utility in its own way. Great. With that, I'll move on to the third and final component of this talk, and that's regarding conducting systematic reviews. So I've shown this already. I'll show it again. The systematic reviews lie at the top of the hierarchy, and these have their own utility in different ways. Before I go into the nuances of systematic reviews, I think it's worth just opening up some questions, some things that might provide some clarity for some people. Is what is a systematic review? That's a question some people might want to know, and I'll get to that. What is a scoping review? They've heard that term before, and it sounds similar and it seems similar in some ways. What is a review? Even that is more basic, but it's something that's not so clearly defined or not so clearly understood by some people. So I think it's worthwhile just delving into that for a brief moment. So the different types of reviews that are out there. There's quite a few. There's one that we commonly hear, literature review, narrative reviews. There's systematic reviews I talked about. I'm going to talk about more. Critical reviews, umbrella reviews, scoping reviews, and meta-analyses. Technically, these are all forms of reviews, but they're quite different in different ways. So honing in on literature reviews, these are kind of what a lot of people more traditionally understand as what a review is. It's going into the literature, finding some articles pertaining to a topic, and trying to understand things. These by themselves are not strictly considered scientific publications. They can be useful, and they're often they may be publishing sometimes, but they're not strictly following a scientific methodology, and for that reason are not considered a scientific article per se. So some of these, I'm not going to go into the exact nuances of the details, but narrative reviews, critical reviews, and umbrella reviews follow they're kind of some kind of variant of literature reviews. But again, these are not what we're talking about today. These are useful. They are useful to understanding the literature, but they're not the kind of scientific publication. So all of those as well as those. And instead, we're going to focus on the systematic review, the scoping review, and the meta-analysis. I'll just touch upon briefly. I'll comment on it now. I'll get into it a little bit later, but they're an add-on typically to a systematic review with an additional statistical analysis. So there, finally, what is a systematic review? I touched upon it. Now let's get right in. So here's a definition. It's quite long, honestly, and it's quite a bit much from a university source. But I thought I'd just distill it down to one sentence here. It's a review of studies that's conducted in a strict and reproducible manner, pardon me, to answer a precise research question. And the point of emphasis is the reproducible manner. That's the element that makes it, more scientific compared to a literature review. Whereas a literature review, you're kind of, digging into literature, you're trying to find what you can here and there to form, a paper or an argument or a structured kind of synthesis of a topic. Whereas a systematic review instead is following a very strict approach that you can describe the methodology and someone else can theoretically get to the same kind of findings that you did by following your approach, just like other scientific articles. So then what is a scoping review? So the difference lies mostly in terms of the actual research question and the research focus. So a systematic review is typically going to have a very strict focused answer. So for example, let's say with GLP-1s, the impact of GLP-1s on suicide risk or the impact of GLP-1s on liver function. Whereas a scoping review is going to take a more, broader kind of approach. It's going to look at the literature as a whole. Not necessarily one strict quantitative question or qualitative question per se, but more what the literature shows more generally. So I'll give some examples here. So systematic reviews. So here's a couple kind of ones I alluded to before. Denosumab for the treatment of osteoporosis. A very strict kind of question. How effective is this drug? What are the side effects? Kind of focusing on that. Another one is comparing two different approaches for understanding pneumonia outcomes. CURB 65 and QSOFA, things, kind of approach scores that people are familiar with in clinical context. Whereas the scoping review, it can vary. So the top one there is social determinants of maternal health and reviewing factors more generally associated with mortality and maternal health use. You see, it's not a health service usage. It's not one specific thing. It's kind of more of a broader landscape that it's trying to gauge. The second one there, so risk act is a specific form of tuberculosis and generally factors that are associated with poor outcomes. Again, it can almost sound a little bit like a systematic review, but again, this is more broad. It can look at population health factors, it can look at clinical factors, it can look at things along those lines. So the lines can be blurry in some cases, but that's a general kind of differentiation between the two. The point of emphasis, though, I'd like to add on is the actual approach that you're going to take that I'm going to describe shortly is quite similar for these. It's more about the research question themselves that's different. So there we go. So systematic reviews. So again, why do these? These are at the top of the hierarchy in terms of evidence. They are the kind of studies, not original studies, but they're kind of studies that are most likely alongside randomized control trials to have an impact on guidelines, to have an impact on recommendations, and to really have effects in the clinical space. So kind of adding to that, it's a high level of evidence. In some cases, it can be the highest, but that's not always the case. So sometimes systematic reviews can be reviews of case reports. And of course, something like a cohort study or RCT might be above that, whereas a systematic review of RCTs might be very, very useful. It can filter bias. It can provide up-to-date information. So if you say you found someone citing a clinical trial from the 1980s about a certain drug, that can be quite useful. But if you also have one from the 2020s, it allows you to kind of, provide a head-to-head and combine comparison with things to understand, here's the flaws of this study, here's the flaws of this study. Together, even if they have contrasting findings, we can provide something of a bit of a synthesis with a systematic review, and that can be quite useful as more and more studies come together. It's not like we're having to start from scratch. This is a new RCT, and now we're going to consider this new one, but instead we're combining this one with this one to have a more combined analysis to understand the literature as a whole. With that in mind, these can be highly impactful in a lot of ways. They are scientific publications that I've already talked about, and they can have quite a bit of impact in the clinical space as a result. And at one point that's also useful, I think, for students or for those who are interested in research but not necessarily becoming full-fledged, dedicating 99% or 100% of their time as researchers is that it can be quite low cost, in some cases have no financial cost in producing and ultimately publishing these, because you can do it by digging through the literature. You don't necessarily need your own lab. You don't need you do need two people to actually do a systematic review, but it's not like you necessarily need a whole staff, a whole university position, and all that. Um, give the example I gave a bit earlier with the medical student suicides. This is an example. There's many examples out there of how, there's something implementable, something concrete can come out of these, and that can have an impact, in the clinical space or the education space, wherever it is. So you'll see numerous. If you look into guidelines, a lot of times the things that are cited are systematic reviews. In some cases, systematic reviews might provide infographics or some kind of guidance for future clinical study, and that's quite warranted in a lot of cases for these kind of studies. So I want to bring that up again to highlight the utility overall. So with that, now we'll move into the actual steps for conducting these. There's quite a bit, and so I'm going to break it piece by piece. So we'll start with the literature search, moving on to developing a research question, developing your criteria for inclusion and exclusion, developing and utilizing search terms, screening studies, extracting data, conducting quality assessments of risk of bias, synthesizing and ultimately analyzing that data, writing up the sections for the actual manuscript, and of course, and theoretically it's the last step, in practice it's a bit different. It's submitting to a journal. I will just briefly add on, there are other elements that are worth considering. I'm not going to touch upon on this talk, like publishing a protocol, like conducting additional statistical analyses, but I'll just bring it there, after submitting to a journal what happens, but I'll kind of limit to these steps because these are kind of the core elements required for systematic review. So in terms of actually connecting, this is the part I was mentioning about having a clear and consistent approach. There's different guidelines, there's different recommendations, there's different checklists that can be utilized. This is one I commonly use. It's not the only one. It's called the PRISMA. So preferred, as you see up there, that's what it stands for. It provides a well-established kind of methodology to follow for your reviews, and by following it, you're holding on to the element of ensuring that it's scientific, to ensure that's reproducible. So this is an example of the kind of guideline that's used, and it's something you should use from the very beginning. So in terms of once we have that, it's a literature search. So in some cases, it might be described as the literature review. So I don't want to make this confusing. I want to make this clear as well. The literature search, formulating the background, the literature review, this is where, you're delving into the, understand the topic a little bit. Not necessarily with the strict scientific searches, but just to understand it more generally, have a gauge of what the research shows. And it's two primary goals. One is to summarize the existing evidence, as well as identifying the gaps. So this is not necessarily, going super comprehensive and publishing a whole paper, but for yourself to understand. And that provides you with the means to be able to develop the research question, to understand what is addressed in the literature, what is not addressed, and is this important? And with those elements, by finding what's there, what's not there, and what's ultimately useful, it provides the means to start with the research question itself. So developing the research question, I'll give the example of a study that was published. Our team published this a couple of years ago. Just bring it here because it's relatively straightforward. We looked into that a little bit. So we looked into what the gaps are. So there's uncertainty for those who are living with COVID-19 as well as with HIV. We know that they're at a risk for poor outcomes overall, but we don't know what the factors are associated with that. So that's the kind of gap, and that's what we found from digging in the literature a bit. And then the purpose comes down to, okay, so this is a scoping review, and we're trying to understand what are those factors. And in some cases, it can be just that, here's the gap, and what is the element of this gap that needs to be understood. So in this case, it's quite clearly just that, what are the risks for these poor outcomes? Next is gauging and developing the criteria for inclusion and exclusion. And this will be integral for ultimately creating the search terms for your paper. So it's going to vary by the topic that you write about, the focus of the research, but there are some general characteristics for most or all systematic reviews or scoping reviews that you can follow. And that's generally that the research the studies are in English. That's not necessarily required. If you are multiple team members are able to speak another language fluently, you can have that. You can have additional articles from other areas. That it covers original research. Again, that's not a strict requirement, but that's typically the case. Commonly, you're going to include the RCTs, the cohort studies, the case control studies, or whatever it is, but not reviews. Though in some, I don't want to overgeneralize that. In some cases, people do choose to include reviews as part of their systematic reviews. And then of course, you're gonna aim it to fit your research question. So in the example that we gave, it's going to be people living. So studies that include people living with COVID-19, living with or had COVID-19 and died from it, living with HIV, and describes in some way or another certain factors associated with that. Again, going to vary depending on your study, but that's generally the kind of approach you're going to take. Um, and next is going to be, and let's quite linked to that is creating search terms. So this can be the part that can be a bit hairy, a bit confusing for people, can be overwhelming. If you have the means, it's useful to have a librarian who's on board to help you. But otherwise, looking at past literature, looking at past studies can be really helpful in doing this in a systematic way. So you're going to go through different databases, such as those on the screen here. And you're going to create terms that you're going to input into each respective database to find as many relevant papers. You want the terms to be broad, and you want it to fit. You'll notice there for each of those databases, there's slightly different, structured in different ways. Mesh terms or the kind of key headings that each database uses. Again, if you have a librarian available who can help you, that can be very useful. But otherwise, looking at past studies and looking at what they've done and what the search terms that they use, particularly those that are relevant to your topic of review, can be quite useful in developing these. And so once you've done that, once you develop your search terms and once you've input it into the databases, such as, for example, with here with PubMed, so we're going to do that search, that unique PubMed search. We're going to save the terms. We're going to save those results. We got 92 in this case, and we're going to export those for the next step. We're going to do this for all the respective databases. And move on to the screening process. So this is the part, and basically the next parts of this of the systematic review or scoping review process requires two different people to do these independently. And so with screening, what you're going to be doing is you're going to inputting those search terms, those search results into whatever software you're using. Some of which are free, some of which are not. These are some examples. You can look up. There's many ones. There's some free ones available as well. And I'll show you, and I kind of just show you to describe it to you what kind of looks like after that. So this is the Prisma diagram. This is ultimately the product of the screening that you'll see, where you're first going to identify the different searches. So that's shown in the top left there. Different databases show the number of results. Either through the software or through manually, you're going to remove the duplicates that's shown on the top right. And then you're going to go through, this can sound overwhelming in some cases, but you're going to go through each and every article by title, by abstract, and screen them based off the inclusion-exclusion criteria that you previously identified to determine what articles are relevant and worthy of being considered for inclusion versus those that are outright excluded. After that, you're going to actually go through each text in totality. So that means actually downloading the text or having it open and going through it and determining more comprehensively if it's eligible for inclusion in your review. You're also going to specify the reason why you did not include the study if you did not. And ultimately, that's going to come out with your product. At the bottom, you see there 28 studies included for your review. So this can vary. There's no right or wrong answer per se. Importantly, as I said before, two people are going to do this independently, and you're going to have a consensus at the end. I've seen reviews with more than triple-digit studies. Some with 28 here. You can have some as low as 3. So here's an example of a study. The main point of emphasis is that last part of the last sentence is that only 3 articles met the selection criteria. Sometimes that's what you get. It's not necessarily because there were only 3 articles found that it's a bad review, that it's a bad topic. In some cases, that's what the research, that's what the literature is available, and that's what you go with. So the next stage, once you have your studies, the ones that you decided to include, you're going to work on extracting the data. And so there's different ways to do this. Again, you want to define in advance what data you're going to be extracting. So I'll show you an example from a different study, a different review, pardon me, on malaria nets and the utility of various malaria nets or mosquito nets in reducing the amount of malaria spread as well as the amount of impacts of mosquito bites. So what we did here, what was done here, first of all, was to just characterize the different elements of the study, to provide a gauge of the research studies themselves. It's not just the findings; it's the research study. It's very useful to understand that. Um, and then along with that is now the findings of the studies, various elements of what they did, what they found, and the different outcomes that were assessed. Because in some cases, people will look at purely the results from your review and the synthesis, but in some cases, people will also want to look at each individual study or look at one particular study. And by presenting in this way as an example of many different ways to do it, you're able to provide that to the author in a very clear, again, a scientific manner. So the next part is a quality assessment, sometimes called the risk of bias. You're going to consider, as I was kind of alluding to before, some of the elements of the study methodology. So the appropriateness of the study design, the interpretations which are incorrect or correct as per your judgment, the sample size, which can be really important. Even though you have two studies included in your review, not all studies are the same. If one has a sample size of 10, another has a sample size of 2,000, clearly one has more potential for impact than the other. Bias, and several other elements of study methodology. You're going to assess all of these, and that'll help get a gauge of the quality of the studies as well as the level of the evidence that you have overall. So the quality assessments, there's multiple tools. I'm showing an example of one that's done where a specific checklist called the Joanna-Briggs Institute checklist was done. You see the different elements that are being asked for and assessed for in the study, and this provides a nice convenient score. It's not necessarily the right way to do it. It's one way to do it. There's also other tools, so risk of bias tools such as those mentioned there. And this is just something that was done in a past review where they provide a very clear visual of the quality of the studies, in which areas the methodology is considered stronger versus weaker. Again, it provides a way for someone to look at the review as a whole, and then on the left you can look at every specific study and kind of gauge of where the studies are lacking and why. So next is the actual synthesis of the data. So this is where you're going to get the findings from the individual studies and put it together. There's different ways to do this. So you can, pool them up arithmetically. That's the study characteristics, and that's the findings of the individual study. And by study, you see, specific elements. And I'll talk about meta-analysis very briefly here. So meta-analysis kind of takes the next step where you're going to pool that data and you're going to do a statistical analysis for the data was there. So say an RCT evaluates the odds of a certain disease progression or the odds of cure of a treatment from a treatment. So a meta-analysis will combine that statistical analysis with another one to almost create a new one on its own. That's the extension that's not in every review, but can be done. This is another example, where it's not necessarily showing, it's not pooling it quantitatively, particularly due to the diverse nature of the literature, but it's more, describing it in a narrative manner to provide a general trend of the literature and what it shows. So with the synthesizing, the next part is actually analyzing the data. It's a so what. It's like, we have all these findings. This is where the researcher's expert opinion, that's where the interpretation of the findings kind of come in. So what do they explain about the world or this phenomenon, our findings? How can these findings bring about change, or how can they not? Can they be a negative finding? What can future researchers do? And connected with that is how can these inform guidelines? How can they inform, public health programs? How can they inform ongoing clinical interventions? And another element of the analysis that's quite important is the limitations. I see some people who are, sometimes a bit shy about describing the limitations of their paper or the review. And I would say it's important to actually be very clear and critical of your own work, both in terms of the review itself and the studies included that formulate the review, because that provides the most honest understanding of the limits of the research as well as the utility that may offer without over exaggerating. Again, really important part. So here are just some couple of different examples for some different reviews. So in this one, looking at how for those with TB, kind of mentioned before, those with comorbidities are at a higher risk of poor outcomes. And so addressing those comorbidities can help with overall outcomes. Another one with the mosquito nets showing that these are quite effective in reducing, particularly those that are infused with insecticides, in reducing malaria spread as well as mosquito bites. And so there's an imperative to help make these more widespread and available. As I kind of alluded to, an important finding itself, it can be a non-finding. So, I bring up, the example of only 3 articles included. That in itself, the fact that there's the literature is lacking can be important because it guides future researchers. It tells us, we can't make recommendations at this time, but maybe in 2 years, 5 years, 10 years, once there's more clear clinical research out there, we can reevaluate the topic. But currently, this is where we stand now. And now I'll just, kind of bring it together in terms of the write-up with sections and all that. So you have, the literature review, your literature search, you have your description of the approach that was taken, you have the findings, you have your analysis, and that's where it comes together in terms of you're writing it. So the background, the literature review and the formulation of that research question, the why you're doing this particular topic is the background. The methods will be, kind of the steps that were described in a very clear and reproducible manner, the kind of what I already talked about. The results, so those are the findings. That's the results of the screening. That's the elements of the studies, as well as the quality assessment or the risk of bias, and then either the meta-analysis or the pooled findings. And then the discussion, the conclusion. That's the analysis, that's the so what, that's the limitations, and that's the next steps forward. Together, you put all those, put a nice little synthesized, 200, 250 word, whatever the journal is asking for, kind of synopsis, and you have basically your manuscript. You have your systematic review. And of course, what I'm describing here is not unique or limited to systematic reviews, but it's generally how manuscripts are written for those who are not familiar. But that's what it kind of formulates. So the next step, again, this is not unique to systematic reviews, but I just touch upon this. Submitting to a journal. You want to find a journal that fits the topic of research. Ensure that they actually accept systematic reviews, and in some cases they don't. Ensure that you can publish in spite of cost. So there's some who are affiliated with Australian universities. Some journals have a means to pay for publications. That's not always the case, but you can, in some cases, publish in subscription journals where that can be free of cost. Ensure that it's your final formatted draft, and that's linked to the next point of don't rush. Don't try to just push out as quickly as possible. Take your time, make sure it's well written, and make sure it's your best work. And don't be let down by rejection. In some cases, journals can reject papers once, twice. I've had a paper that was rejected about 15 times, but ultimately it can still get published and it can be quite impactful. So that summarizes, the elements of steps for conducting a systematic review. I know this is a whole, a comprehensive and in-depth kind of diagram, but I've tried to break it down for you. And that's the presentation as a whole. Thank you so much, everybody, for coming today and for listening. These are the references. And now I believe there may have been questions have been asked, but if there's any questions that anyone wanted to pose, I'll open up the next slide here and I'll try to answer the questions as they go in the meantime. So for the evaluation, sorry, just
Karan, there is one question
Oh yeah,
I'd like
sure.
to pose to you. So
Sure.
what tips would you give to someone with no medical research experience in breaking into the space and equipping yourself to be successful?
Yeah, it's a very valuable question. I think it's something that's hard for everybody. There's no cookie cutter one all be all answer. I think coming to events like these can be useful and quite valuable. And understanding the process and what you want out of it can be useful. I know it's not necessarily, the black and white kind of, okay, here's what I can do, but I think starting with that is useful. Understanding what you want, why you want, and what you can offer. And then sometimes it's trying to reach out, finding people who are doing research. There's a lot of people who, especially those who are aware that, people who are starting out find it difficult. Finding someone, clinician, it can be a researcher, it can be a professor, seeing if they have any availability of projects. So when I first got started, I was doing a master's degree and I had the privilege of working with some professors and, they were open to recruiting different people. I think reaching out and offering something and being genuinely passionate about it, even if it's not necessarily or showing interest in the topic, interest in being able to wanting to help out. So even if it's a topic you're not necessarily the most passionate for, I think that's okay. Trying to reach out and just being someone who can offer, who's willing to be a sponge and learn, who can be patient with the process. And once you start getting the ball rolling, just with any other skill, learning a language, trying to get into medicine, whatever it is, then you start to get the ball rolling. You understand a bit. When you get that first publication, it can be a real boost. And that still holds. Trying to learn from others, trying to be involved wherever you can, and being open, being flexible, can be, all that's part of it. Yeah, I hope that answers things.
Yeah,
Yeah,
perfect.
very good. Were there any
Thanks.
other questions? I can't say right now. Are there any others that you wanted to share with me, Addison?
Uh, there's one more.
Sure.
It's about thinking sort of what's currently evolving and changing in the research space, but around the use of AI in assisting with literature searches and stuff like that.
Yeah.
Is that becoming part of your research process? What do we need to think about when we're doing that? And,
Mhm.
um, you know, does it actually help us?
Yeah, thank you. Thank you. I deliberately chose to exclude that from my slides because I was aware that it opens up a wormhole, but it's a very valuable question. I think in today's, time and age where AI is everywhere and it's around us and it's very useful, it's not something you should be scared of. It's a very valuable question. I'll tell you what my approach is currently, and that's evolving itself, is I personally, when I, work to publish papers, I'm very aware that some journals have very strict policies of no AI usage is allowed, or yeah, in some cases it can disqualify publication. In some cases you have to describe it. Currently, my approach is I avoid using it. That I'm not saying that's necessarily the right approach or the best approach, anything. I think what's most important is a couple things. One is whenever you do it to be as transparent as possible. Don't never lie. Make sure you're clear about what you did and why. Um, how I think I would recommend to people at a stage where they're still learning, I'd say try to do as much as you can yourself. If there's clear either from your team or from the journal clear bounds by which it's allowed, you can use it. But I think it's helpful more so, especially for people who are new. But I also do this as well, is in the brainstorming process. So not necessarily writing your paper, but starting from step zero of where can I begin to start looking? What can be some good articles to look at to help me understand search terms? And from there, just like with so many other domains, AI can be the launch pad as opposed to the means that's doing it for you. I think maybe in some days and months and years, my answer might become outdated, but that's currently the approach that I take, and it's working well for me now. I think that could change over time.
Excellent.
Yeah, great.
Well, thank you for that. So that is about all we have time for this evening. Also aware that Karan has to go and work a night shift tonight. So thank you so much for giving us your time and your brilliant expertise. 50 publications and still as a resident. That is absolutely phenomenal and just shows how much of a passion you have for it, but also the experience to have that much publication. So, thank you for sharing all that with us. So, this evening, we're just going to share a couple of things with you in the chat in just a moment. But we'd like to ask if you could this evening, could you please complete the evaluation, of which the link will be in the chat? As well as there's also a link that you can generate your CPD certificate for attending tonight's webinar. And there's also the link to our website where you can watch all of our past webinars, and a recording of this session will be made available there if you'd wish to go back and revise the content on that. So you can scan the QR code that's on the screen to get to the evaluation, or the link is within the chat there. One person who completes the evaluation will go in the draw to win a subscription to one of our either basic science, clinical medicine, or junior doctor packs for providing that evaluation. So thank you again, Karan, for this evening, and wish everyone well, and we'll see you at the next webinar.
I just want to say thank you as well, Addison, for the kind words, and thank you everyone for taking the time out of your evening to be able to come and listen today. Hope you gained something of value.